Thank you very much, and a very good afternoon to all of you. And I'm thankful for the organizers of the conference for letting me sharing the experience of the university where I did this study. So basically what we are looking for is, I'll be going through, the format of my presentation would be, I'll be sharing some data and some reports of the Enterobacter sepsis in the literature, and then talking about the emergence of the resistance and the mechanism of resistance of this organism to the different antibiotics which are being used. And then, of course, sharing the data of my study. So basically, it was an increased incidence of the multi-drug resistance Enterobacter sepsis in a tertiary care setting, and it's over a period of 3-year study in a teaching hospital, which was 600-bedded hospital. Neonatal sepsis is one of the most frequent cause of admissions in any tertiary care neonatal intensive care unit, and it is the most important cause of the neonatal morbidity and mortality worldwide. Incidence varies from 1 to 2.5 per 1,000 live births. More than 40% of our under 5 mortality, if we look at the figures, is basically related to the neonatal mortality, which accounts for 3.1 million deaths all over the world every year, annually. And if we take into account the portion of the neonatal mortality, it's about 1/3 of that. So about 1 million neonates are dying each year because of different causes, and the majority of them, among them, are dying of infectious causes. That means neonatal sepsis. On the other hand, if we are able to survive these neonates who end up with infection, then of course the short and the long-term neurodevelopmental morbidity is very high in these neonates. Neonatal sepsis, we all know we can categorize as early onset and as late onset sepsis, depending upon the occurrence of the infection and the time period. The spectrum of organisms that can cause neonatal sepsis are again wide, but can be divided into gram-positives and gram-negatives. And among the gram-negatives, Enterobacter septicemia have in recent years emerged as an important cause of the hospital-acquired nosocomial infections in NICUs. During the past years, there has been a change in the common pathogens which cause neonatal sepsis, especially if we are talking of extreme preemies and premature, low birth weight babies and high-risk neonates who are admitted, where highly specialized interventions like mechanical ventilation, central venous line insertions, umbilical artery vein line insertions, TPN nutrition, and umbilical placement and catheterization is being carried out. When one looks at the different case reports, the rate of the late onset neonatal sepsis is more common in premature and low birth weight babies as compared to the term and good weight babies. And looking at this study from the NICH reports that 21% of the low birth weight babies will end up, who are less than 1,500 grams, will develop one episode of a blood culture proven late onset neonatal infection, and the rate is inversely proportional to the gestational age. So the younger the gestational age, like at 22 weeks, the chances of infection is 58%, while at 28 weeks, it goes down to about 20%. Now, incidence of the late onset neonatal sepsis is inversely related, as I told you, to the maturity, and also varies with the geographical area where they are being treated. And it is from 0.61 to goes to 14.2%. Looking at the epidemiological data on the low birth weight babies shows that the predominant pathogens for the late onset infection basically are our gram-positive, like the coagulase negative staph, which are followed by the gram-negatives, in which the Enterobacter has emerged as one of the common organisms, and then, of course, you have the candidial infection. The thing which which is unique for the Enterobacter is that it is well adapted to cause nosocomial infections as or is ubiquitous in the environment and can survive on the skin and the dry surfaces, as well as it can replicate in the contaminated fluids. And the numerous outbreaks have described, including that these outbreaks occurring from contamination of the enteral feeds, humidifiers, and the respiratory therapy for the different hydrotherapy. Going through the literature, we have a case reports of an outbreak of the cephalosporin-resistant Enterobacter cloacae infection in one of the neonatal units, which was reported by Modi in 1987. And there what he reported that resistance to the third generation cephalosporins was an outbreak in the NICU, where ampicillin and gentamicin were used as a first line for antibiotic treatment as neonatal sepsis, and the resistance to the cephalosporins was also isolated at that time period in 12 infant neonates. If we see this report, and this is a 25-year study which was published, where they had again seen an outbreak of 29 episodes of Enterobacter cloacae infection occurring in very low birth weight babies, and the time of onset of infection was late onset, ranging from 4 days to 70 days. Another report, if we look at, is published, done by Lowell in Pediatrics International in 1999, where again he reported an Enterobacter outbreak in an intensive care unit, and another one which was done by Harvard, showing an increased incidence of Enterobacter over a 22 years period of area. Looking at the different organisms internationally in different parts of the world, and if we look at the Enterobacter, which is actually, I don't know whether you can make out the color, it's blue over here. So you can find, this is the staph cons coagulase negative Staph aureus, which is of course prominent as one of the organisms all over the world. But then Enterobacter you would find reported from different parts of the world. So the distribution pattern of the causative organisms depends upon the region and may change over time within the same hospitals. And depending, this is due to the demographic pattern of the patients and the microflora contamination and colonization of the nosocomial environment and the policy of the antibiotic use, which is a very important element in the development of resistance pattern. Now, in any unit, the protocol of selection of the antibiotics depends upon the frequency and occurrence of the type of organisms and, of course, their sensitivity pattern to that antibiotic. Looking at, if you look at the antibiotic selection, of course, the management plan will depend upon the antimicrobial therapy which is being used for the Enterobacter sepsis. Beta-lactams are the main drugs to which these organisms are sensitive, and the carbapenem are the most reliable beta-lactam drugs for the treatment of the severe Enterobacter sepsis. The fourth generation cephalosporins is another choice. The second and the third extended spectrum cephalosporins develop resistance to these organisms very quickly because of the beta-lactam induction. So fourth generation is another choice. For the aminoglycosides, resistance is again relatively common and is widely reported worldwide. Coming to the fluoroquinolones, the resistance to them is still rare, but in some areas of the world, we have got case reports of resistance to our quinolones also. Last but not the least is the colistin and the polymyxin B. And these drugs are being used frequently to treat very serious infections, especially in cases of MDR or multi-drug resistant cases. Now again, it should be noted that the application of the broad spectrum antibiotics in the past has basically contributed to the development of the multi-drug resistance gram-negative bacilli, and they account for about 20% of the normal neonatal bacteremias, and for the 2.5-fold increased mortality than the non-MDR organisms. I think one of the reasons which has been reported even in the literature is the empiric use of antibiotics, which is often inappropriately and unnecessarily used as a broad spectrum coverage, and especially if it is done for a prolonged period of time in premature babies. Now, the increased number of the multidrug resistant gram-negative organism in intensive care units, as we know, is increasing worldwide, and it is of great concern, which of course requires the thorough surveillance strategies and appropriate antibiotic regimens, treatments to be adapted. Now, as I told you before, that if we have reviewed the literature also, that the antimicrobial resistance is a growing challenge, especially if we have a critically ill neonate, because for a neonatologist, it's a nightmare to have a micropremy in the unit and where the culture report comes as multi-drug resistance organism. So how to go about it? So basically, escalating rates of the antibiotic resistance have added substantially to the morbidity, mortality, and of course, the costs related to the treatment of these neonates. Now, given the increased resistance rate of the pathogens and relatively slow development of our antimicrobial agents, the antibiotic stewardship program is basically designed and it is implemented in hospitals to optimize the antibiotic therapy for the newborn babies. And as I've told you before, that the incidence of resistance to the third generation cephalosporins, penicillins, and quinolones is basically increasing. The third generation cephalosporins and the monobacterium, like the astronym, have approximately the same incidence of emergence of the antibiotic resistance to our Enterobacter infections. How they develop the resistance, we all know that in vivo selection of resistance to the fourth generation is little lower because the organism needs mutation at two sites. One at the loss of the porine protein, which affects the permeability of the cell wall to the agents, and second is the overproduction of the cyclic AMP beta-lactamase. Therefore, the resistance development to the fourth generation cephalosporins is relatively less common. And here is again a case report of development of cefotaxime-resistant Enterobacter, the strain which was cefotaxime MB lactamase. And this strain was first reported from Brazil, but then later on this was reported from, again, different parts of the world, Far East, Middle East, and South Africa. So that means the problem is worldwide. Again, the aminoglycoside resistance to the Enterobacter is basically induced due to plasmid-mediated aminoglycoside modifying enzyme. And that's how they develop very soon resistance to the use of the aminoglycosides like gentamicin and your amikacin. For the carbapenem, the resistance is less common, and because it needs mutation at two sites, one at the porine protein losses, and second, the beta-lactamase induction. Therefore, relatively compared to the cefotaximes and the third generations, carbapenem still are the drugs which can be used. So it's very important for the neonatologists and the microbiologists to periodically evaluate the spectrum of the organism causing neonatal sepsis in their units and to determine the antibiotic policies with reference to the resistance pattern of the organism. It is also of paramount importance to look into the risk factors for the development of resistance to these antibiotics. Only after that one would be able to decrease the emergence of the resistant strains of neonatal sepsis and, of course, secondary to decrease the morbidity and mortality related to the neonatal sepsis. Keeping all this in mind, we carried out a study to look into the occurrence of the Enterobacter outbreak in our unit and the emergence of the resistant pattern of the above organism to the commonly used antibiotics. so that the protocol guidelines could be prepared regarding the selection of the antibiotics and secondary measures to be taken to prevent the development of the resistant strains of the Enterobacter. This study was conducted in the NICU of Ziauddin University Hospital, which is a 600-bedded teaching hospital, and the time period was from Jan 2010 to 2012. So it was a 3-year study. The blood specimen for cultures were drawn from 2166 newborn babies who were admitted in the NICU with clinical signs of sepsis. Repeat blood cultures were sent when the neonate did not show signs of improvement or deteriorated on the first-line antibiotics. A single sample of 2 to 3 ml of blood was collected and it was incubated in a brain-heart infusion broth. The colony isolates were identified by their colony morphology and by using the API 200E gallery system for the Enterobacteriaceae. And the antibiotic resistance pattern was studied by the modified Kirby-Bureau disc diffusion technique. If required, then further samples like a urine culture, a CSF culture, skin swab cultures, ET tapes, UAC and UV tapes were also sent for culture and sensitivity. The onset of the Enterobacter cloacae infection in our unit ranged from 7 to 35 days after birth. The mean age was 11.4 days. When we looked into the spectrum of the organism causing late onset sepsis, we had this type of profile. And among the gram-positives, the most common organism was Staph epi, which out of total cases, it was 27.7%, followed by Staph aureus, which was 10%. Among the gram-negative organisms, we had 84 cases of Enterobacter, which was 15.5%, followed by second organism, which was Pseudomonas, and this was 7.96% of the cases. This is the breakthrough of the first common, I just took the first 2 common gram-positive and gram-negative organisms in our late onset sepsis. All the neonates were initially kept on the broad-spectrum intravenous antibiotics, and the combination which we started when this study was done was cefotaxime and amikacin. The reason why we did not use ampicillin in combination with gentamicin was that most of our E. coli had shown resistance to ampicillin, and GBS was not an issue. We have not seen GBS as one of the infection in majority of the NICUs in that area. The antibiotic regimen was modified when the blood culture results were known. Organisms showing sensitivity to the carbapenems were treated with meropenem along with amikacin. The Enterobacter positive cases, they occurred in clusters at intervals lasting from 4 to 6 months. And in our unit, all the neonates were housed in 6 cots per cubicle with 6 separate isolation beds. And let me tell you, this is a very busy referral unit. So more than 50% of the neonates which we were treating were being referred from other different neighboring maternity clinics and hospitals. Due to high admission rate at the time, sometimes it was difficult to isolate the infected babies from the outside referrals. Now, the Enterobacter was the most common gram-negative isolate from the period from Jan 2010 to December 2012. And what we saw was a decrease in the incidence of the early onset sepsis and a rise in the incidence of the late onset sepsis with Enterobacter, and the incidence was 4.6 per 1,000 live births. Tightening of the infection control measures, particularly frequent hand washing and cohort isolation of the infected neonates along with fumigation of the unit resulted in subsidence of the clusters. The source of Enterobacter was blood, like the blood culture positive in 89.28% of the cases. And as I said, it was late onset in majority of these cases, which was 82.14%, Out of these were the late onset infections. Enterobacter was grown in 84 cases. And this is the breakdown of the early onset and the late onset for our Enterobacter cases. So majority were occurring in the late onset time. The mean birth weight of these infants with Enterobacter sepsis was 1750 grams. Mortality was very high because of the development of the multidrug resistance, which I'll just share with you, and it was 47.61%. The mean interval between the onset of symptoms of sepsis and the death was 7.4 days. So this is the basically different samples. In 75, which is 89.28%, the blood culture was positive for Enterobacter. ET tip was positive in 2.3%. Urine culture was positive in 7.1%. CSF, we didn't get any CSF positive culture where we did the lumbar punctures. And the umbilical catheter trip was positive in one case. A urine-variate analysis of the risk factors revealed a significant association between the low birth weight and the prolonged stay in the nursery for Enterobacter sepsis. And of course, the resistance pattern, if we look, the resistance to the both drugs, cefotaxime and amikacin, was 79.5%. A high mortality rate coupled with a short interval between onset of symptoms and death suggested a high virulence of the strain. And looking at the resistance pattern, as I said, its majority were resistant to the first line, which was cefotaxime and amikacin. This is the graph which I would like to share with you, and this shows the percentage of resistance pattern. And this is for amikacin, 64% resistance, ampicillin, 93% resistance, cefotaxime, 85% resistance, gentamicin, 83% resistance. For carbapenems, we had one case of imipenem resistance, which was an MDR, which was resistant to all the drugs, and we had 4% resistance to the meropenem. This is the basically antibiogram which our hospital sends periodically, and you can follow. This is year-wise, the first year, second year, and third year. And this is like the isolate Enterobacter, 21 in the first year, 14 showing resistance to the ampicillin, 16 showing resistance to cefotaxime, and that's how we were following the 4 years periodic antibiograms. This is for the second year, where we had 45 cases of Enterobacter, out of which 34 showed resistance to the ampicillin, and cefotaxime, 41% showed resistance to cefotaxime. This is the second year. Then coming to the third year. In third year, we had 18 cases. Amikacin resistance was 6, where we had changed to gentamicin because we have cyclic change of antibiotics. Cefotaxime, the resistance had gone to 14. So in the third year, the resistance pattern to the first-line antibiotics came down. That's the antibiogram for the whole of the hospital for the ICU, PICU, and NICU, the total number of cases for that. Enterobacter sepsis, we saw, was more common in males as compared to the female patients. And in 79.5%, it showed multi-drug resistance to the first-line antibiotics. Now, looking at the prominent risk factors like the sex, predisposition, prolonged rupture of membranes, prematurity, low birth weight, ventilatory support, and the invasive procedures in NICU, these all were analyzed in context with the prolonged use of antibiotics. And the risk factors which were identified as a major cause were 3: a low birth weight, prematurity, and the prolonged stay in the NICU was significantly associated with the emergence of Enterobacter, which was multidrug resistant. Looking at the p-values or the significance, significance was with low birth weight, prematurity, and of course prolonged stay in the NICU. So basically colonization was believed to the nosocomial spread through the hands of the nursery personnel due to inadequate hand hygienes and overcrowding. We went through some interventional strategies, and the strategies which were applied in the unit after the outbreaks was performing periodic prospective audits and intervention feedback. So whenever we had positive reports, we had an audit of those cases and the interventions. Antibiotic stewardship program was started, which was basically cooperating with the local microbiology and the infection control committee to regularly monitor the adequacy of the antibiotic regimen, because the pattern of the causative pathogen and antibiotic resistant profile changed over time, and avoiding unnecessary use of broad spectrum antibiotics for presumed sepsis. So this was another thing with the stewardship program. We came down with the unnecessary use of and prolonged use of antibiotics. Now this is a very important slide, that the best strategy for the late onset infection is the prevention. So besides strict adherence to established infection control protocols and less invasive interventions in the NICU, current evidence suggests that strict hand hygiene is the most effective measure for prevention of the late onset neonatal infections. And adherence to the infection control policies, including, again, to strict hand hygiene and the antibiotic stewardship program, are required to decrease the number of the infections in any hospitalized neonates. So that's what we had done. We went through the pharmacokinetics and the pharmacodynamics, basically rules, maximizing the dose of aminoglycosides. We are worried, of course, for the side effects of aminoglycosides, its neurotoxicity and ototoxicity, but keeping in mind if you do the trough and the peak levels, but keep the aminoglycosides, if we are using them, to the maximum dose. This helps in decreasing the development of resistance to the organism, and a combination treatment for synergistic effect. These are two things for the antibiotics. Second is the computer-assisted program and the other educational interventions. Whenever the gram-negative bacilli are isolated from blood, the program provider recommended for empiric treatment based on the recommendations from the infection control consultant group. And a microbiology data would become available, and that was incorporated in basically recommending to short-line the use of antibiotics. And where we found resistance to the broad-spectrum antibiotics, as use of just carbapenems like imipenem or meropenem was good enough to treat those infections. Infection control was of paramount importance, so hand hygiene attention and measures to be done. And what we found that the non-compliance was seen more in the NICU as compared to ICUs and PICUs, and during high-risk procedures and during the weekends. So these areas were targeted more seriously. Use of gloves for all patient contacts was done, but again, something which was observed, that change of gloves didn't take place while examining one baby to the other. So that was important, and cohort isolation. Nursing was very important for prevention of these outbreaks. This was again a very important point. As I told you, our hospital is a very busy hospital and a referral center with a very high delivery rate for itself. Adequate nursing staff. So we found that the outbreaks occurred where we had overcrowding, too many babies, and there was shortage of the nursing staff. So termination of the outbreaks was accomplished by decrease in the crowding and workload and increased attention to the aseptic techniques, especially your hand washing. Antibiotic cycling, another important factor which played a part. So 12 monthly scheduled change in the empiric antibiotic therapy. So we made an alteration between cefotaxime and amikacin, and ampicillin and gentamicin as the 2 cyclic drugs as the empiric treatment. So coming to the discussion, in this observational study, we described the epidemiological characteristic of the Enterobacter sepsis outbreak in the NICU and analyzed the major risk factors for the development of the Enterobacter sepsis. This indicates a nosocomial infection of 84 neonates with Enterobacter sepsis over a period of 3 years with a crude rate of 53 per 1,000 admissions. The 2 organisms which were isolated from our unit was the Enterobacter cloacae and the Enterobacter aeruginosa, which were the basic ones. And overall, over the last decade, previously less common organisms like Enterobacter has been identified as a more frequent isolate as a cause of the nosocomial spread in our NICU. They are difficult to treat because of the emergence of the multidrug resistance to the most commonly used antibiotics which are available for the NICU. And our study confirms the association of the various risk factors to the development of Enterobacter sepsis in the NICU setting with the other studies, especially the prolonged use of antibiotics secondary to prematurity when the babies are on ventilatory support, on different aggressive interventional procedures, catheterization and others. And also our study verifies the length of stay in the neonatal intensive care unit as a major statistically important risk factor. So the longer the babies stay in the NICU, the higher are the chances of developing this infection. And bacterial surveillance, however, might permit the rational use of antibiotics in different units. So this is an important report showing that some previously described risk factors for the development of Enterobacter sepsis were equally applicable in our present study. And increasing survival of the low birth weight premature babies may require multiple invasive procedures, which are ventilation, intubation, catheterization, TPN, and others. And they all provide a favorable environment for the continuous presence of the Enterobacter as a cause of neonatal sepsis in any NICU unit. So prolonged stay in the NICU and low birth weight and prematurity were the main factors related to the neonatal sepsis. Prolonged use of antibiotics may also result in the emergence of the multi-drug resistant stains. Now further studies are needed to establish the role of the antibiotics in the emergence of the multi-drug organisms in any neonatal intensive care unit. And these are the references. Thank you.
So one question we would have is, what was the length of ventilation day for the premature infants in your unit, the average?
In our units, we were taking babies like 28 plus weekers.
Okay.
So about more than 50% at any given time were premature babies.
Okay. Because one of the newer strategies for neonates is to extubate to high-flow nasal cannulas. Is that a procedure that you all do?
Yeah. All the recent modalities of non-invasive ventilation and going for minimal procedures, these we have, previously it was not followed as religiously, but then we have gone for this, and luckily in the last 2 years, we have not seen all those cases which were there.
Yeah, in the past, the previous ventilator strategy for neonates would, excuse the term, make it a BPD breeding ground. Yeah. And so with the ventilation of low pressures, extubation quicker, this tends to decrease the amount of chances of infections that babies can get.
One thing which again we had swapped for was the insure technique. So in fact, if baby needs surfactant, so just give surfactant and extubate, and that really helped also in eliminating all those prolonged stay in the NICU on ventilation.
Correct. Thank you.
See, these were all cases of late onset. And we know anywhere in the world, if you look at the data reported, staph epi is one of the common organism as a gram-positive pathogen for late onset neonatal sepsis. Luckily, we didn't have MRSA, which is another organism which we see, but we didn't see any of the MRSA in our unit. We did see staph aureus, but that was sensitive to the first-line antibiotics.
Secondly, it's surprising such a huge incidence of such a huge number of cases resistant to quinolones. Even we are not using quinolones in that era when this study was conducted. It was very limited use of quinolones in countries like Pakistan or Europa, but still a high number of patients resistant to the quinolones.
No, let me tell you, my observation in the area where we were working, many cases were referred to us like at day 5 or day 7 from different other hospitals. And there has been use of quinolones in those areas, in many of the units. So probably I would say misuse and overuse of the drugs is one of the possibility.
What is the incidence of Group B strep?
We see in Pakistan, if you look at the literature, there are just two reports, one from Peshawar long time back. Presently, I'm working in UAE, in Dubai, and we see a lot of Group B strep. For some reason, in Pakistan, we don't see Group B strep. We don't see that. E. coli as a first, early onset, E. coli is the commonest organism. Then we have Klebsiella, and then we have Proteus and Pseudomonas among the gram-negatives as early. But we don't see Group B strep. Yeah, very common.
What's the incidence of vancomycin-resistant
staph? Yes, we do see that, and especially as I told you many times, we did have vancomycin-resistant staph in our studies. I think that was, if I remember correctly, about 5%. But we do see that. We do encounter vancomycin-resistant staph. We do have a lot of cases of strep pneumoniae, which are again resistant to vancomycin.
And did you use polymyxin in any of the cases?
We had to use, one case which was resistant to all. I used polymyxin B as nebulization. And that really, and we were able to survive that neonate.
Wow.
As situation where things which are not recommended, you at times forced to use them. So we used it as nebulization therapy, and it did have a good effect.
You had to come outside the box.
Yeah.
Last question.
Yeah.
At a tertiary hospital or referral hospital, you are doing that. This is the first blood culture. Are you getting this one, or the second blood culture after 7 days of treatment or something?
See, in most of these cases, the first blood culture was negative. So it was like the first blood culture negative. You start the child and baby on the first line antibiotics, and then you find that the baby is either have a period where the baby will settle down, and then again develop signs and symptoms of sepsis later on. So then we sent a repeat blood culture. So that, in most of the cases, it was the second blood culture which was sent. The first was negative, but the second blood culture was positive. Yeah.
Thank you for an excellent talk, Dr. Fasih.
Zareen?